So the first specimen is coming from a 72-year-old female. So this is a CSF specimen. The patient had the past history of lung adenocarcinoma. So this is the cytospin preparation with loose stent. So this particular specimen is a little bit busier because when we usually see metastatic adenocarcinoma in the CSF specimen, the most common pattern would be large single cells with relatively like a rounded, smooth nucleus. However, in this specimen, it seems to be like in the background there were a lot of cells, uncertain if it is inflammatory cells. Here it looks like a histiocyte. Sound like a more bizarre cell over here. So it is a little bit uncertain what is the nature of these like other more irregular cells, whether these are histiocytes or whether these are metastatic cancer. So I do a TTF1 scan and the alcohol fix papamnicolaou scan. So the TTF1 will highlight the metastatic adenocarcinoma in the nucleus. So you can see the brown color stem with the nucleus. So indeed, in the background, they are metastatic adenocarcinoma. However, these other cells seems to be like a reactive inflammatory cell without the stem. So because of the staining, we are confident that they do have metastatic adenocarcinoma, but the amount are relatively scant. Most of these cells are likely inflammatory cells or the other cells coming from the brain. So this is positive for adenocarcinoma. So maybe the patient do have, in addition to the metastatic adenocarcinoma, she do have meningitis or some other pathology in the CNS system. So this specimen is coming from a 63-year-old male who presented at our emergency department. This is a pleura effusion specimen. So the requisition sheets, the doctor didn't mention about the patient's past history. So the patient has been diagnosed with lung cancer. So in this specimen, this is relatively common that we will see for this pleura effusion specimen. In the background, usually we will see some individual cells, include like lymphocytes, histiocytes, as well as some mesothelial cells. So these are the normal pleura effusion specimen component. So when we when we examine this type of specimen, we will usually want to look for so-called second population, two-cell population. So we will want to look for mostly like aggregates or highly atypical cells that looks different from the innate population of the cells. So here we do see one very big cells looks like multinucleated. So in this single cell, it has a lot of atypical nucleoside all within the single cells. If you take a look of the nucleus, you can appreciate cherry red prominent nucleoli. The nucleoli is as big as the adjacent lymphocyte. So this is metastatic carcinoma. So this is a malignant cells. So because the patient has past history and he has been treated, in the treated patient, sometimes the cancer cell can be quite scant. So here again we see a relatively different groups of cells, also with a highly atypical nucleus. So if you can take a look of the nucleus, it is not rounded as what we will see in the adjacent cells. It has a very strange shape. For the chromatin pattern, you can appreciate that it is quite irregular. We see large clump of chromatin and an area of pale without chromatin. So this is kind of atypical. So this is also consistent with malignant metastasis. So here again we have a single cells. The nucleus is pretty big. It is not rounded. It is like a crescent. And the chromatin pattern again is very irregular. Additionally, the cell is eccentric, which means that the nucleus is at the one side of the cells and the other side in the cytoplasm, possibly some material pushing the nucleus away, and likely a mucin material over here. So these are all evidence of this is a poorly differentiated carcinoma and likely an adenocarcinoma. So in the cell block preparation, we have very scant typical cells here, just like what we see in the cytospin preparation. So we have scattered like these bizarre large cell with multinucleation, irregular nucleus, prominent nucleoli. So this is kind of scattered. So initially, because in the requisition sheets, they didn't put the history, so I thought this is a new patient. Whenever we have a new patient, we will do a TTF1 to confirm if this is coming from the lung primary. So for the cell block preparation, I do order a TTF1 stent. So here you can see this is the malignant cell with prominent nucleoli, eccentric, very big nucleus. So it is negative for TTF1. So this is relatively unusual. So when I go back to the clinical history, initially the patient's lung adenocarcinoma indeed is TTF1 positive. So through the treatment, could it be the result of like a poor differentiation and then turn into like a phenotype conversion into a TTF1 negative cells? We don't know. So for these cases, we will call these non-small cell carcinoma. We won't specify it as a adenocarcinoma. So occasionally, rarely we will see these phenomena, so-called like a phenotypic, like a transformation. So the next specimen, 46-year-old female. So again, very young. This is coming from, again, pleural effusion. She do have a past history of lung adenocarcinoma, which was just diagnosed this year. So lung adenocarcinoma has become the most common cancer now in Taiwan, and more than half of the patients with the initial diagnosis of advanced stage, which means the tumor cell likely already in the pleural cavity. And in this situation, cytology specimen is the most commonly the very first specimen that we can make diagnosis of this patient. So again, the patient has been diagnosed and has been treated. So in this specimen, the tumor cell is very scant. So here we have these cluster of cell. The nucleus is highly irregular and it is hyperchromatic comparing to the adjacent normal-looking cells. The nucleus is not centrally located. It is eccentric to one side of the cells. So this is likely an adenocarcinoma. And I have to give our cytotech credit because this specimen is very difficult to screen. So she's doing a good job by highlighting these cells. They are very, very scant in the specimen. So the patient also had a cell block preparation. In the cell block, we see the tumor cell is easier to identify because you can appreciate that it is irregular and eccentric as well. And additionally, it's easier to see a bigger cluster of cell. And here we even see the central necrosis. So because of the scant cellularity, I still do a TTF1 to highlight the tumor cell. So as you can see, indeed, the tumor cells are relatively scant. Most of the cells in the background are inflammatory cells, but still we do have scattered metastatic adenocarcinoma in these specimens. So this is positive for adenocarcinoma. So pleural effusion is our, like a body fluid, pleural effusion and ascites are our most common specimen, one of our most common specimens. So the next specimen is coming from ascites. So this is coming from the peritoneal cavity. The patient had a history of pancreatic adenocarcinoma. So the tumor is different from what we just see. We see 3 cases of lung primary cancer, and this one is coming from the pancreas, coming from the GI tract. So usually for the pancreatic adenocarcinoma, it is quite common that you can see these small but tight and like a tubular architecture. So this is the second population that we encounter in these ascites specimens. So the tumor cells are actually quite plenty. When you go to higher power, so the difference between the pancreatic cancer and the lung cancer is that the pancreatic cancer frequently has intracytoplasmic mucin. So in this case, you can appreciate that in these cells, they seem to be polymorphic and they have a lot of cytoplasmic vacuole pushing the nucleus away. The nucleus itself doesn't show like a irregular chromatin, relatively like a regular, but still you can see it is like a small vesicular pattern with a very small nucleoli. So this is positive for adenocarcinoma. Additionally, you can appreciate there is a mitosis over here in this cluster. So these cluster of cells are like quite plenty within these ascites specimen. Most of the tight aggregate cells are cancer cells. So this is positive for adenocarcinoma, and the cytomorphology is compatible with pancreatobiliary origin. So the next specimen, pleural effusion. Patient had a history of lung cancer. Again, this is a recurrence setting, so the tumor cell can be quite scant. But in the background, that we still see these tight 3-dimensional overlapping cluster of cells. The nucleus does show these like irregular coarse nuclear, like a chromatin pattern, and small nucleoli, arranged very tight like a glandular cluster. So this is positive for adenocarcinoma. Sometimes in the recurrent setting, the clinician want to have these specimens to do like a drug-resistant mutational testing. So we still need to evaluate the cellularity, whether the tumor cell is like a plenty or not, to facilitate the molecular testing. So the next specimen is coming from ascites. So the patient has a past history of gastric cancer. So this is a cytospin preparation. So for this cytospin preparation, you can appreciate that majority of the cell has these centrifuge artifact that flying away from this circle. So sometimes this type of artifact is make us a little bit difficult to interpret the cell morphology, because the cell morphology can get distorted. But just on low power view, you can appreciate that majority of cell looks very, very dark. So seems to be hyperchromatic. And when you go to higher power, most of the cells are individual cells. So this is very common to see single cell, individual cell pattern in a gastric cancer. So the patient do have fully differentiated gastric adenocarcinoma, so likely a single cell. So here you see a cell with a very prominent nucleolus. Right adjacent to it, there are a lot of cells showing this shrinkage, like a degenerative or necrosis pattern. So these cells are all adenocarcinoma, fully differentiated. So here again we see the cell has like a beating of the nucleolus. So this is individual cell necrosis, which is also suggests this is a malignant tumor. So in this specimen, most of the cells are actually cancer cell. Just we do see a striking like a centrifuge artifact. So at the beginning, it may not be easy to interpret, but still, these cells are all malignant. And here you see a necrotic cell over here. So this is positive for fully differentiated adenocarcinoma and compatible with the patient's history of gastric origin. So the next specimen is coming also from the ascites. The patient had a relatively unusual history that we will see in the ascites specimen, which is breast cancer. So usually the breast cancer, when it go to the body fluid, it will go to the pleural cavity first. But the patient already developed liver metastasis, so it is already go to like below the diaphragm. So in this specimen, we don't have a lot of tumor cells. We have these tight cluster of cells. And if you take a look of the nucleus, we do see like a vesicular chromatin, prominent nucleoli, arranged in a very tight cluster, which is different from the like a normal mesothelial cell histiocyte as a single cell pattern in the background. So this is consistent with metastatic breast cancer, and the specimen has very scant tumor cells, but because we see these so-called second population, the more like aggregates of cells, so this is diagnostic for carcinoma. The next specimen is even more uncommon. We've seen many specimens from this patient for the past few months. This is a 65-year-old male. So this patient had the past history of salivary duct carcinoma, and we already see the prior pleural effusion specimen from this patient. And so again, this is again a pleural effusion specimen. On low power, you can appreciate it is very dark, like a sea of very dark cells. When you go to higher power, these cells mostly arranged in a single cell pattern with relatively smooth nuclear like a contour, but the chromatin pattern is highly irregular. And you can appreciate a lot of these cells does show so-called eccentric pattern, which is not normal if it is a mesothelial cell or histiocyte. So we are pretty confident that this is a tumor cells. This is a tumor cells. This is a tumor cells. Then you can take a look of the background, more bland-looking cell. They are also looks very similar. So let's say most of these bigger cells are indeed cancer cells. So this is a carcinoma already become fully differentiated. So we do see a lot of like these single cell looks a little bit bland in the beginning, but as you can identify these like tumor cells, and the adjacent cell basically looks very similar, and then you can conclude that most of the cells are actually cancer cells. So this is metastatic salivary duct carcinoma, which is basically a salivary gland version of breast cancer, a ductal carcinoma. So this is positive for carcinoma, compatible with the patient's past history of salivary duct carcinoma. So we move to fine needle aspiration. The first specimen is coming from thyroid. So when we interpret thyroid aspiration, we we want to see if the specimen has a colloid background. If we has a plenty of colloid, it's more likely to be a benign hyperplastic lesion. In this specimen, in the background, it is very clean and we do not see any colloid, but we do see aggregates of cells, mostly in flattened, like a single cell like a monolayer pattern. So we want to go to higher power to check the nuclear feature, whether these cells have a nuclear feature of PTC. And here you can see this is intranuclear pseudo inclusion. And most of the cells has relatively irregular nuclear membrane and the oval shape. So this is consistent with papillary thyroid carcinoma. So again, we go to the other cluster. The nucleus contour are irregular and oval, angulated, and with some vague groove pattern. So again, very similar, like an irregular contour and with like a vague groove pattern. So this is the direct smear. In the direct smear, we also see these like relatively irregular nuclear contour, and here is a pseudo inclusion over here. So this is consistent with papillary thyroid carcinoma. So the next specimen is coming from the salivary gland. So this is a liquid-based cytology. So on low power, you can appreciate that we do not see many cells, but a lot of degenerative debris, like a clotting together. So when we go to higher power, so for these debris background, you can see they are shadows of individual cells. But it does not look particularly like a dirty. Let's say we do not see a lot of like nuclear debris or PMM, like acute inflammatory cells, just like a degenerative cellular debris. So when we see these type of debris, this is very classic to see these as a content of a benign salivary gland tumor called Warthin tumor. So whenever we want to diagnose Warthin tumor, we want to identify benign oncocytic cell with a typical morphology of a Warthin tumor. So for the liquid-based preparation, we only see the cystic debris fluid. In the direct smear, we again do not see any like epithelial component, but only these degenerative cellular debris material. So in this situation, usually we will use non-diagnostic like a Milan category 1 to sign out the report. But before that, because we have the residual liquid-based cytology specimen, we can use that to do a cell block to confirm that if there is actually no epithelial component. So for the cell block preparation, we do identify these columnar shape oncocytic cells along with these lymphocytic like a stroma. So these indeed look like a Warthin tumor. Here again, a fragment of epithelial element with like a elongated columnar shape. And here we have some more. So this is consistent with a Warthin tumor. So because of the cell block preparation, we can call this case as benign Warthin tumor instead of non-diagnostic. So this is the application of cell block. Sometimes in these degenerated cystic aspiration, we won't see epithelial cell. So we will need a cell block to help us to identify them in the residual specimen. So finally, let's take a look at some pap smear. The first case is coming from a patient with a past history, a 56-year-old female who had a history of ovarian cancer with carcinomatosis, who has received surgery. So this is a post-hysterectomy pap smear, which means that the uterine cervix already been taken out. So usually in this specimen, we won't expect to see glandular cells. However, occasionally, we will still see like a endocervical glandular-like cells in post-aspiration patient. So here, this is benign-looking glandular cells. And we do see superficial squamous cell, intermediate squamous cells. Here are a few cells with multinucleation. And the cell has a very big nucleus. So these cells look quite suspicious. Additionally, the chromatin pattern is kind of irregular comparing to the adjacent cells. So we start to see some atypical cells with very big nucleus. So here again, we have these cluster of cells. If you compare the nucleus to the adjacent normal-looking intermediate cells, this is gigantic, like a very big nucleus. The nucleoli is also very big, bigger than the adjacent lymphocyte, and it is not rounded. It has a very strange shape, arranged in a tight cluster, and it is well preserved. So this pattern is what we call alien pattern. So this looks like an adenocarcinoma, high-grade adenocarcinoma, out of nowhere present in the pap smear. So this is most likely because the patient don't have uterine anymore. So this is most likely metastasis, or because the patient do have the history of ovarian cancer. So this is likely just recurrence at the vagina. So this is positive for adenocarcinoma and consistent with the patient's history of high-grade serous adenocarcinoma.帮我拿下那边片子，谢谢。Yeah, so final specimen is also pap smear from a 64-year-old female who had the past history of CIN1. So since 2023, we have called the case CIN1, and the patient has positive HPV other type, non-16, non-18 HPV high risk. So in 2024, 1 year after, the pap smear is also CIN1, low CO. The biopsy is negative. So last year, we diagnosed the patient with ASCUS cannot exclude high CO, and the patient had a biopsy confirmed as low CO. So in this situation, we know that the patient had a chronic HPV infection and resulting in a precursor lesion. So we have signed out the case 2 year as low CO. The 3rd year as low CO cannot exclude high CO. And the biopsy only approved low CO on the 3rd time, which means in this situation, it is quite common that the precursor lesion is deep inside the endocervical canal. So when you do the biopsy, it is only the axial cervix, not easy to get deep into the endocervical canal, and they possibly did not get a good like a biopsy of a representative lesion. So because the patient already is 64-year-old, so you can appreciate the smear show an atrophic background. In atrophy, the intermediate cells will change from polygonal shape into a more rounded shape with relatively increase of NC ratio. But still you can appreciate that the nucleus is very rounded, is very smooth, the chromatin pattern is very delicate. So this is a typical background for atrophic like cervix. Additionally, for the atrophy cases, it is not uncommon you can see more tightly aggregate intermediate cell as a bigger like a fragment or cluster. So you have more like a cohesive cells in larger fragment instead of only the individual cells. In atrophy, it is common to have atrophilic vaginitis, so you can see some inflammatory cells in the background. So we start to appreciate, just on this intermediate power, you start to appreciate some cells has bigger nucleus and it looks darker comparing to the adjacent normal cells. So this cell looks kind of suspicious, but because it doesn't show good preservation with the cytoplasm, it is a little bit difficult to definitely call it something. So here again, we have these pyknotic cells. So the chromatin pattern is like a smash, so you know this is highly degenerated. However, comparing to the adjacent normal cell, this cell just looks very hyperchromatic. So this is again not the benign finding, but however, just based on these degenerated cells, we are not comfortable to call these positive for like a high seal. So for this specimen, we have individual cells of these relatively like a bigger nucleus and a more prominent like a coarse chromatin pattern, but it is kind of scattered throughout the like a smear, and we do not see good focus of the edges of the good focus of cells that are unequivocal for low seal. So again, you see this much darker cell and with bigger nucleus, but the cellular border, the cell membrane is not very clear. And it is actually throughout the smearing direction, which is important which means that they sample the lesion. There is a focal lesion at the cervix. And again, with these like a very dark pyknotic nucleus, not well preserved, but looks kind of suspicious. So for this case, we will use ASCUS cannot exclude high seal for our diagnosis, because these cells do looks very atypical, but it is mostly degenerated, not well preserved. So we will use ASCUS cannot exclude high seal for this case. So ASCUS is not enough. Okay, thank you for your attention.